Good afternoon, everyone. We're going to give just one more minute for others to join and log in, and then we'll get started. Several folks are logging in, so we will wait one more minute and then we'll get started. It's exciting to see those numbers climb.
And all the different wonderful roles that people have. It's very exciting.
Absolutely. Okay, I think we're ready to get started. Let's get this show on the roll. Good afternoon, everyone. It's so great to see all of you putting your names and titles and information in the chat. We're so excited to have you. My name is Dr. Dana Hunter, and I'm the new Executive Director of the Louisiana First Foundation, founded by Louisiana's former First Lady, Mrs. Donna Edwards. Mrs. Edwards is also the founder of the National Coalition for the Prevention of Human Sex Trafficking, or NCPHST, the lengthy NCPHST, as we like to call it, a coalition of first spouses dedicated to raising awareness of the issue of human trafficking, some of which you will hear from today. On behalf of NCPHST, we want to welcome you all today to the ninth Global Human Trafficking Prevention and Awareness Summit. We are excited to share with you that we have over 260 registrants for this event. And for those of you who are joining us, we would love to continue to know who you are, as some of you have already started putting your information in the chat. Those of you who are just joining, please take a quick minute and share with us your name, title, and agency that you work for. Today's topic, we will discuss the intersection of traumatic brain injury among victims of interpersonal partner violence and victims of human trafficking. You will hear from national experts who've been immersed in research on ways to identify traumatic brain injury, or TBI, and steps involved in treatment and promoting equity, healing, and justice for survivors of violent crimes with traumatic brain injury. To get us started with today's program, it is my honor to introduce to you all an advocate who's used her platform as First Lady of Louisiana for more than 8 years to raise awareness of the issue of human trafficking. She now continues in this role on the national level through her National Coalition for the Prevention of Human Sex Trafficking, or NCPHST, and on a global level as a board member of the Santa Marta Group. I introduce to you all Mrs. Edwards.
Good afternoon, everyone, and thank you so much for joining us. So May, it's already May, is the National Foster Care Awareness Month. Partners and professionals across the country are engaging in activities to raise awareness of the plight of youth in the foster care system and ways that we can support foster youth. As many of you may already know, the National Foster Youth Institute recently estimated that 60% of child sex trafficking victims have been within foster care. So it is important for us to continue having these conversations about what human trafficking looks like and how we can educate those around us on what to look for. And we also need to continue raising awareness about the many vulnerable facing this population and other individuals who are vulnerable to all other crimes of exploitation. I'm so thankful to have here with us today several experts who will share information with us on the risk of traumatic brain injury in victims of human trafficking and intimate partner violence. And I also want to take a minute and acknowledge the first spouses who are here with us today and members of the National Coalition of the Prevention of Human Sex Trafficking. So here with us today are First Lady of Kentucky, Brittany Bashir, and former First Lady of Arkansas, Susan Hutchinson. And I was going to let each of them take a brief moment to say hello and share a few remarks with you. So is First Lady Bashir on yet?
This is her Chief of Staff, Kinsey Morrison. She had to step away for a moment, but is so appreciative of being part of this advisory board. And thanks all of you for being here today.
Thank you so much. We appreciate you zooming in. Former First Lady Hutchinson, Susan.
Yes, it's so great to be with you again. I'm so excited you're continuing on with it since we first met 9 years ago, and you became interested. And it's a parallel work with what I was interested in, still am, with children's advocacy centers. And we have a newly elected Attorney General, Tim Griffin, who came on board and went immediately to work in 23 to look at the legislation. Needed to be strengthened and all. ASA was able to get legislation that decriminalized the victims of sex trafficking, the minors. So that was a big step for Arkansas. And Tim Griffin, Attorney General, has worked on that with more legislation. He also, in October 23, right away, last October, hadn't been there a full year, he created a summit in person on sex trafficking, and it brought in some 1,500 people across the spectrum. 1,500 people came in and to coalesce to get together with that. So he subsequently started a collaboration amongst law enforcement, and it calls it the Statewide Tactical Operational Partnership. So he can get all the law enforcement folks on all three levels of federal, state, and local to work together to combat this gross activity that's in our country, nationwide and worldwide. Glad to be with y'all.
Thank you so much, Susan. And Susan has worked for quite a long time on the Children's Advocacy Board for many years. So thank you, Susan, for that and for continuing your work. Also, we appreciate you so much. So thank you all. And I now let Dana introduce our presenters, who I know you're going to be thrilled to hear about today. You're muted, Dana.
Thank you. Thank you, Mrs. Edwards and members of the coalition. Thank you again for your dedication and leadership to raise awareness and eradicate human trafficking. At this time, we will hear from leaders and experts in the field who have advocated for policies, programs. They've gone before state, national, international leaders to work on this issue of traumatic brain injury and to really bring exposure and light to this issue among vulnerable victims, including those of interpersonal or intimate partner violence and human trafficking. And so, first, we will hear from Dr. Zussman. Dr. Zussman is a nationally respected trauma surgeon known for her clinical research on brain injury resulting from domestic intimate partner violence, child abuse, sexual assault, and human trafficking. Dr. Zussman started at Northwestern University Medical School at the tender age of 19. She did general surgery internship and neurosurgery residency at UC Davis Level 1 Trauma Center in Sacramento, California. She served as chief neurosurgery at the Mayo Clinic Network, many roles. She's also an adjunct full professor and has been invited to present her research findings on brain injury at several institutions. It is our pleasure to introduce our first presenter, Dr. Edie Zussman.
Hi, it's my pleasure to be here and my honor to have the opportunity to say a few words about brain injury, which is my lifelong expertise as a trauma neurosurgeon. It's something that we take care of every day, but it wasn't until we saw an increase in the number of women being referred to our traumatic brain injury and concussion clinic during COVID that we began to really do a deep dive on what was going on with heretofore unrecognized brain injury resulting from domestic violence, sexual assault, and intimate partner violence. And for the incredibly diverse and impactful group we have put together for today's event, for our symposium, I wanted to give it a structure of where we all fit. So everybody on the call today, everybody attending this seminar is on this line, and we have different ways in which we impact and with which we engage with people who've experienced domestic and intimate partner violence, people who've experienced trafficking, people who've experienced child abuse. And this was something we put together for the mayor of Los Angeles, the city attorney, LAPD, LA Fire Department, just like former First Lady Hutchinson said, it's gotta be everybody working together. And for the first part of the presentation, I'm going to put on my neurosurgical hat and talk about traumatic brain injury. And I'm going to give everyone on the call a little bit of I'm thinking of it more like a common language to communicate around what a brain injury is. And I particularly want to point out that there are two types of brain injuries that are occurring in our sexual assault and traffic population. And one of them is what we think about, like the trauma that our sports players play, where their head is hit, where they're shaken, like mixed martial arts, where there may be kicking. But in this particular group, we've got a second injury that layers on top of it. And I would imagine that many of the folks on the call are very familiar with the role that strangulation is playing in the sexual assault population and in the traffic population. And so essentially what I want to share is that when we think of traumatic brain injury and we think of sports and we think of football, this group has the elements that come from sports and car accidents and falls. But there's a second element that may be equal or more important, which is a change in blood flow to the brain due to choking and strangulation, and a decrease in oxygen to the brain. And so from the perspective of a neurosurgeon and the brain injury experts, we're counting all of these as events. So if there is a concussion, where somebody has an event that they can't remember, for example, or where they know that they lost consciousness. There's a traumatic brain injury where they actually have longer term difficulties, perhaps with speech or with moving part of their body. What we're learning from the football world is that the subconcussive blows, the individual hits, the smaller events are likely adding up. And in our community, that may be things like being shaken or being slapped. And we found that when we started including this concept of subconcussive blows, the pervasive nature and the repetitive nature even increased. And I think one of the things to share is this concept of strangulation. It's now starting younger and younger for people who feel like they're making choices, like they're making a volitional choice to include that in their practice. And we don't think there's a significant difference in those two settings. So I'm going to go ahead and advance the slide. So as chief of the Mayo Clinic Network affiliate, one of the first 100 women neurosurgeons board certified in the United States, we built this traumatic brain injury and concussion clinic. And oddly, during COVID, we were seeing 2.5 times as many women as we would normally expect to see. And I asked the medical student rotating with me, can we look over our cases? Who are the women? And found out it was domestic violence. And having never taken care of concussions and domestic violence before, it wasn't something that we learned in medical school or in my residency. I asked them to look in the literature and, give us guidelines. What can we do to take the best care of this new population that we were seeing? And it turned out there were no guidelines. There were no standards of care. There was nothing in the literature that helped us understand the nature of brain injury in an abused and trafficked population. And so we started not only doing our own research, but culling elements of research that Mandisa, future Dr. Keswa, will be presenting in the next talk. What we did do, though, is we compared our group of domestic violence survivors with all the other types of concussions, and there were no differences on MRI, no differences on symptoms. The only differences were gender, time to referral, 6 weeks versus 6 months for survivors of intimate partner violence, and the number of concussions. So before they referred to a concussion clinic, if it was an athlete or someone with a car accident, they had 2 to 3 lifetime concussions. If it was somebody referred to domestic violence, they had 6 or more concussions that they knew about. And that becomes super important because as a neurosurgeon, if I'm seeing a professional skier and they've had 3 or 4 concussions, we talk about pulling them out of skiing. And we all know that we've watched football on the weekends. And if there's somebody who has a significant injury, what happens? Play stops. The experts come and evaluate that individual. They aren't even allowed to go back to practice if they've had a concussion until they've been screened by someone with my level of training and education. And when we think about the lifetime risk of concussions, once you hit a threshold, and it's different for different people, different backgrounds that they have, different mechanisms of injury, but we're pretty confident that somewhere between 4 and 6 lifetime concussions is where we start seeing a huge increase in risks for long-term changes, permanent, not reversible changes. And so we really want to think of brain injury as a game stopper, where we educate individuals, and as soon as we have the opportunity to evaluate for brain injury, we make sure that they know that that's an additional risk. And this is something that the medical community has not been aware of. I think it has to do with some of the biases that we have in healthcare. And, I was trained at Northwestern University, top medical education, and we were taught that when a man comes in like this fellow here with his dark glasses, when he comes into concussion clinic, we're taught that he's wearing the dark glasses due to light sensitivity. And the medical term is photophobia. And that's a medical condition and a hallmark of concussion. We were literally taught that when a woman comes in with this example, and she's wearing dark glasses, that it's likely because she's embarrassed, that she's hiding bruising for her eyes or face that the makeup couldn't cover. And at that moment, when I saw those patients about back to back in my clinic, I realized that I too was missing the fact that we were giving men with the same set of symptoms a medical diagnosis, and we were giving women a psychiatric or psychological diagnosis, such as battered women syndrome, battered person syndrome. And so one of the messages for our conference today is that brain injury is often considered invisible. We've got folks who look just like you and me who've had multiple brain injuries. And so how do we make it visible? And the speaker after future Dr. Keswa is Dr. Monahan, and Dr. Monahan is going to take on making brain injury visible for all of us together today. And so what are some of the symptoms that a survivor of brain injury might describe? Headache is a really important symptom. If somebody comes in and you're engaging with them, whether it's in the justice system, whether it's in the shelter system, whether you're in healthcare or social services, if somebody comes in and the bright light's bothering them and you almost feel like you want to shut off the fluorescence, or they say, boy, you know, this is a really noisy room. I'm just overwhelmed by all the input. If they tell you, oh God, my migraine's back, my head hurts, and it turns out it's a particular type of headache. It's one that comes up this way from the back of the head and neck. It almost looks to me like a whiplash type of headache. So you can imagine the impact. We know that the medical presentation of strangulation is sometimes a hoarse voice, difficulty breathing, difficulty swallowing. But I want to make sure you all know, and Dr. Monahan will reinforce this, the majority of symptoms related to a brain injury. And that's for anybody. That's for an accountant in a car accident. That's for an ICU nurse, you know, who fell. That's for a Berkeley PhD student who got hit in the head with something that fell on her head at work. The number one symptoms that patients present with are mental health symptoms. They'll say, I just feel hopeless. I don't feel like I'm myself anymore. I feel like my brain is slow. I'm not thinking as quickly. I'm not able to multitask. And then what we look for is their actual objective findings when somebody gets referred for a concussion or trauma evaluation. We look at things like, when do they see double? So looking at one finger, bringing it forward, everyone sees double at about 6 centimeters. My TBI patients, they see double at like 2 feet, at 1 foot. And my football players, it's really a powerful objective finding. They'll tell us that when they get up too quickly, or if they're in the shower, they feel like they're going to faint. They describe that headache with the pain sometimes coming up from the back. If they're in a room with a lot of things going on and a lot of distracting noises, or even if they go to the store, if the lights are bright and there are a lot of people moving, there are a lot of colors on the shelves, they'll be like, oh, you know, I can't block out the information that's not important. I can't focus on one thing. And then they also show some difficulty with balance, particularly when their eyes are closed. And so we did some prospective data collecting now, and to call out the fact that with the domestic violence and intimate partner violence, a lot of folks have violence at home and then they go to work where they're actually safe for that period of time. With the trafficked individuals, they are unsafe where they live because of their trafficker may also be a domestic or intimate partner abuser, and they're at risk when they perform and are engaged in trafficking and the work that they're doing. And so in a population from the greater New York area, we asked domestic violence survivors coming into the shelters, what were some of the things that you experienced within the last year? And I think you can see, and I'm glad we're recording this so that we have this information, but people are kicked, punched, struck with objects, pushed to the ground, slapped. And their symptoms, primarily headache, also being unable to remember the trauma. And I think this is going to become really important. If we interview somebody, or we're a first responder or someone in the legal profession, and somebody says, first I was upstairs and then I was downstairs and I don't remember how I got from upstairs to downstairs, the current formulation is that means they're hiding something. They're lying, they're trying to protect the abuser. As a neurosurgeon, when I hear that, that is my diagnosis of concussion. And so we found that 57% of people who answered our questions coming into shelter in New York had had a concussion within the last year. And before I present the next image, I want to say that there's a trigger warning, and that anybody who'd like to turn off their camera or step away I wanted to show some of the anatomies so that you can think about these events the way I think about them. The concussion is if the head is shaken, like if you think about being seatbelted in a car and you're hit from behind, your head goes forward. It doesn't have to hit anything to get a concussion. It's just the stretch right at the connection between the neck and the head, the occipitocervical junction. So it's the brain hits the front of the skull, even if it doesn't hit against anything. And then in this population, we've got folks who talk about being hit with objects, being pushed against the wall, being pushed against the floor. And then we add to this population uniquely that not only do they get the same injuries of a car accident in sports, but we also have that loss of oxygen, loss of blood flow, and elevated pressure to the brain, which leads to particular changes in memory, forgetfulness, particular changes in frontal lobe and decision-making. So if I see a patient who's survived a car accident and they come in and the first example that I'm going to share is a accountant, and he's been married for 36 years and he belongs to a country club and he comes in with his wife in his Argyle sweater. He's never had any of the aces that we think about among the people that we know. And he tells me, he says, you know, Doc, ever since that car accident, I can't go into Starbucks anymore. I said, well, why, Mr. So-and-so? Why can't you go into Starbucks? And he says, because if someone cuts in front of me in line, he goes, I want to hit him. So something to think about. So that's what a traumatic brain injury looks like to me. This is a PhD grad student who got fired from a pizza place because she couldn't remember the pizza orders. Well, she doesn't know, it's 2 years out. She didn't realize how severe her brain injury was because it's invisible, even to the individual. She looks fine. She's been able to manage with her friends, but she couldn't remember the 13 different pizzas that she needed to bring out. And this ICU nurse, these cardiac ICU nurses are so cool. They're like the ultimate of calm under pressure. And she says, you know, ever since my event, if I'm cooking dinner and my twins are fighting and the phone rings, she says, I feel so overwhelmed. I go into my closet and cry. And so to me, that's what a brain injury looks like. And now let's superimpose that onto the types of individuals that we're seeing who aren't coming in with one brain injury from one car accident. They're coming in with recurrent brain injuries. They may have had a childhood injury, and then now they're an adolescent and they're having subsequent injuries. And they may play volleyball. They may have injuries from their sports. This story was really touching to me, and it was a mother who lost custody of her children after domestic violence. The court, as well as the abuser, had gaslit her and said, well, you forget to pick up your kids from school all the time. You're a bad mom. And I said, look, if you had had a car accident, we teach you to put an alarm on your cell phone and make sure to, you know, do a reminder at 2:30 that the kids come out at 3. The reason you forgot your kids is because you had a traumatic brain injury. And this woman sat up and she crossed her arms, and I will, for the sake of the recording, bleep the swear word, but you can insert it here. She says, you mean that blank who pushed me down the flight of stairs is why I lost my kids in custody. And then this gal's a pole dancer who got pushed out of a moving vehicle on Interstate 80. And she came in with her mom, and right away she was very bruised. And I said, look, if this were a sports injury, we would make sure that you were safe for the next 4 to 6 weeks until you recover. I will see you every week, just like I see my athletes. And would that be okay? Mom, can she stay with you? And she stayed. And at the end of 6 weeks, we were able to release her back to her job. The mom drove her to pole dancing. And we asked her, you know, what did this mean for you? She said, look, Doc, if you would have told me that day that I came in that I couldn't go back with my boyfriend, she goes, I would have gone back that day. She said, the only reason I stayed until my head cleared was because you said I had a concussion and that my mom was able to take care of me until it got better. She goes, now there's no chance I'm going to go back. She goes, you know, I get what happened. And I understand that if I get more injuries, that I'm even at more risk. So we mentioned already the risks of strangulation, and people will say all different ways. Sometimes they'll show you, sometimes they'll say I was choked, and sometimes they'll say I was strangled. We know that strangulation and brain injury means that violence can even escalate. And this is where we see our our murders and our deaths, including our deaths of police officers. It's the #1 risk for loss of life for active duty police. I want to have everybody know that if you take a story, what happened to you, and someone starts saying, I can't remember, or you ask them about their childhood and they say there are elements that I can't remember, yes, it can be both. Yes, it can be a psychological block, but I want you to know first and foremost, that's the flag waving that there might have been a brain injury. It's the first thing we ask. If there's a car accident, we say, well, what do you remember? And, you know, the grandmother who was making a left turn into the church parking lot to pick up her grandkids, she says, well, I remember putting my left turn signal on. And then the next thing I remember is the ambulance coming. That's loss of consciousness. So if there's a gap in the story like that, I want to make sure that everybody on our call today, everybody on our symposium, begins to think of that differently. And if you're in a position as a first responder or a doctor, I want to make sure we hand that off. I want to make sure we say there's a possible brain injury here. You know, let's make sure that there's a full evaluation. The other element that I think is really important is that sometimes the signs and symptoms don't occur right away. And medical doctors, as well as our first responders and justice system, we gaslight here. We do. And we say, well, when the police were there, you said you were fine and didn't need to go in. Or when you got into the emergency department, you know, they screened you and everything was fine. Why now, 2 or 3 days later, you say your head hurts and your neck hurts and you're all forgetful? Totally regular, absolutely expected. In fact, so much so that we go ahead and educate anybody who comes in with a concussion to see their doctor a week later. And we tell them to be aware that there may be symptoms that come up. So this is what we're dealing with. We've got 25% of women, 10% of men over their lifetime who've had these types of lived experiences. We're going to talk, Mandisa is going to talk next about how this is concentrated in our trafficking population. But where are folks who have brain injuries? We know that they're among our trafficking and sex workers. We know that there are persons of color, LGBTQ+, child protective services, unbelievable prevalence of brain injuries coming into child protective and then during the child protective time. Migraine headaches clinics, Alzheimer's clinics. I highlighted this because so much of what we're doing now is labeling brain injury symptoms as mental health. The #1 symptoms for school-age kids after a head injury from, let's say, skateboarding is attention problems. So attention problems in a school-age child is another one of those flag wavers. Substance abuse, homelessness, incarceration. And with that, Dr. Hunter, would you like to introduce our next speaker?
Sure. Thank you so much, Dr. Zussman, for sharing that knowledge and expertise and just for giving that culturally responsive and trauma-informed care to your victims. And even in your research, really looking at it from a trauma-informed, the ACEs lens. So thank you so much. And next, we will hear from a devoted advocate for survivors of domestic violence and exploitation. Future Dr. Mandisa Kezwa is a first-year medical student at Kaiser Permanente Bernard J. Tyson School of Medicine and a Pomona College graduate with a BA in neuroscience. Originally from South Africa, Mandisa grew up in a small town outside of Philadelphia. She's worked with survivors of DV and IPV and sexual assault, collaborating with domestic violence organizations to work within the legal privilege of confidentiality. With her background in advocacy and community support, she plans to pursue a medical career utilizing tools of compassion and sensitivity that encompass her work in sexual assault and brain injury awareness. It is my pleasure to introduce to you all today future Dr. Mandisa Kezwa. Mandisa?
Thank you so much for that introduction. Hi, everyone. It's really, really great to be here. I was actually just thinking back to my first time actually meeting Dr. Zussman was in a space just like this. I had had a lot of questions after working in advocacy and having a lot of peers of mine who would confide in me, and I did a lot of hospital accompaniments. And it was astonishing hearing about those narratives and hearing about how much sort of overlooked neurological injury was occurring in some of the people that I was helping. And I was a neuroscience major, so I was already really fascinated with the brain and the intricacies of sort of social being too. And so I connected with Dr. Zussman because she was kind of asking similar questions as me. So I'm going to talk a little bit more about human trafficking. And I know Dr. Monahan is also going to go ahead and do that too. But I wanted to talk more about prevalence. I wanted to talk more about what we know. And again, special shout out to Sydney Myers and Sonia Lee, also integral parts of Safe Living Space, and have done some amazing work in also trying to pull out what we know about prevalence and how pervasive this issue is in populations who are experiencing exploitation and human trafficking. So what do we know currently about human trafficking? So in terms of kind of a broad definition, human trafficking is the use of coercion and deception of individuals for the purposes of exploitation. And this can look really, really different depending on who's being trafficked. So oftentimes it's sexual in nature, but it can also mean labor and just other forms of exploitation that are either children, women, predominantly. So among women who are subjected to sexual exploitation, there are various cohort studies and a lot of bridging information coming out about rates of domestic, interpersonal, and physical violence. Currently, that number is estimated to be at 70 to 90% of individuals experiencing some form of violence during trafficking. So really, really high rates. And then women are disproportionately affected by trafficking. So women and girls, so it is people who are underage children, 70% of those are sexually exploited. The average age of women who are involved in trafficking is 30, and the average age, unfortunately, of children is 11 years old. The average duration of labor and sex trafficking is about 2 years, and oftentimes people will be sort of in and out of trafficking. So they'll experience 2 years and then intermittently go back into it. And then just to give you kind of a schema of what this process looks like, and also just a point of reference for intervention, the various points of intervention that we have to try to make a difference in this space. So there's pre-departure, and that essentially the idea behind trafficking is that traffickers will try to get at the most vulnerable people that they possibly can. They'll prey at a lot of vulnerabilities that people experience. And so that's age, that's gender, it's socioeconomic status. So people who are maybe impoverished or have just lost their housing. Also people who maybe don't have a social support system, who are very isolated. And then there's the transit process. So a lot of times that means borders crossed. And then there's use of documentation that's forged. So there's all of these little nuanced parts of trafficking that really, really provide us with context about what the transit looks like and how these individuals are exploited. In terms of exploitation, again, a lot of that is sexual violence, and a lot of those individuals experience some form of physical violence. A lot of times there's things like threats to individuals or family or to their health. And a lot of the characteristics behind that too are just taking away basic needs. So food, water, the ability to move around. And in some cases, they're not able to get medical attention. So in terms of rates of physical violence, a sort of diagram that I wanted to show you all. There was this study that was actually performed from this really large database of trafficked individuals. It's called the IOM Victim of Trafficking Database. And it's, I believe, the largest database on human trafficking that's at least worldwide. And they actually pooled about 10,000 trafficked victims and tried to garner information about the rates of physical violence. And they included sexual violence as well. And you'll see that, again, astonishing numbers. About 50% of those 10,000 trafficked victims had experienced physical violence and 15% sexual violence. And there's also a category where they included both together. And I also want to call out that they actually looked at both male and female trafficked individuals. So I will be talking a lot about women and children, girls, but I also want to make sure that we're thinking of other genders, and I'll talk about transgender individuals as well. Anyone is susceptible to this. Okay, so in terms of understanding prevalence, the reason why we're asking this question is because a lot of the research studies that are done that focus on trafficking really emphasize mental health disorders. This is something that Dr. Zussman already talked about, but we tend to see a lot of PTSD diagnoses, anxiety, depression, things that are really relegated to psychological, mental health, emotional health. And there are a lot of guidelines currently for providers and other people sort of in the social spaces about addressing human trafficking in those individuals specifically. But that focus is mainly identification, response, but the response being trying to ensure safety, maybe housing, privacy of those trafficked victims, trying to get them out of being trafficked and being in those environments. Currently, though, there's a gap in terms of management of these head traumas, these brain injuries that are likely happening because of these really high rates of physical violence that we know and that are substantiated in the literature. And so that was kind of the basis of this next step, which was trying to get a sense of what the prevalence is in terms of sustained head and neck injuries among trafficked populations. Do we have a count on that? Is there a range that we can look to in the literature? So what I did was I actually did a comprehensive literature search. So I looked at really prestigious databases, trying to get a sense of whether or not there have been direct studies about this. So I used inclusion criteria like trafficking, prostitution, sex work, and cross-referenced that to brain injury, head injury, strangulation. And there were 45 total papers that I was able to find that in some way addressed this intersection. And only 5 of those actually assessed prevalence and had a specific number that they were able to identify from their sample. So this prevalence ranged from 12.5 to 100%. So huge, huge range, but I want to call your attention to the next line, which is the average across all of the studies that I looked at. And that was 68% of the subjects had in some way sustained a previous head injury associated with being involved in trafficking. And again, I want to call out that all of these journal articles were about sexual exploitation, and trafficking can encompass many, many other forms of exploitation, but this is currently what's been focused on in the literature. Okay, and just to give you a sense of what some of these prevalence studies looked like, the very few prevalence studies that I was able to find. So this one study looked at 65 women who were escaping prostitution in a few different places, San Francisco, Chicago, Toronto, Canada. And maybe this looks familiar to some of you or it's circulated in some way, but they found that actually 95% of those individuals had sustained head injuries at some point during trafficking. And that consisted of really just devastating things, being hit in the head with objects, having their head shoved into objects. And you'll see that that's 89% and 74% of those 65 women. And then to the right over there, you'll see that there's kind of a breakdown of symptoms that they started to associate with these patient narratives and experiences. Headache, migraine, dizziness, memory loss, some of which can relatively easily be conflated with things like anxiety, depression, chronic fatigue, sort of these emotional and mental health diagnoses that these women might get. And it can be really hard to try to separate that from physiological things like sustaining a brain injury or a head and neck injury. So in terms of demographics, about 2/3 of the individuals described themselves as women, and 1/3 described themselves as trans women. And then ethnicity and sort of racial breakdown was 65% were African and or Caribbean, 23% were European American, 8% Latina, and 3% American Indian. And as I mentioned before, a big part of trafficking is individuals trying to get at vulnerabilities and use that as a way to deceive and exploit individuals. And some of those things boil down to socioeconomic status or isolation. And those tend to happen in certain social groups. Thanks, Dr. Zussman. Okay, so to talk a little bit more about sort of another study that kind of fits in a different context, one of them that was described was actually about asylum seekers and refugees. And what was interesting about this study was it was 115 adults that were actually pooled and who were asylum seekers, and were pooled because they had sustained some sort of psychological trauma. So they actually went to this community psychological trauma service because they were referred with mental health problems, sort of inattention or depression, anxiety, things like that, things we've talked about before. But what was interesting about this was that this community organization actually decided that they were going to screen for head injuries. They were going to screen for potential brain injuries among these participants. And they just used a questionnaire. I don't think it took super long. And they found that the overall prevalence among this population was 51% had at some point sustained a head injury. A large proportion of those had been associated with being trafficked and largely across borders. And 38% of those individuals also had persisting disabilities that arose from that traumatic brain injury. So an example of that is like hearing loss. In terms of social implications, it's also interesting because the asylum process is heavily reliant on applicants being able to talk about detailed and chronological explanations of where they were leaving from, why they're seeking asylum. So individuals who can't recall an order of events properly and sequentially are not credible resources. And that has huge social ramifications for people who are really trying to just get to safety. Other considerations, impulsivity, increased impaired judgment and aggression, things that we see time and time again in head injury. Those can have a dramatic effect on these asylum seekers and refugees being able to be protected. And then to kind of just close it off, I wanted to call back to what we know about risk factors. So we talked about prevalence, and we also talked about how being of a certain identity, being part of certain social groups also is clinically correlated to trafficking and then also experiencing physical violence that can result in brain injury. So we talked about asylum seekers. And then there's a lot of data currently about how racial and ethnic minorities disproportionately are affected as well. Transgender women, again, looked at a study of 10 women that were involved in sex work, and 90% of those participants, transgender women, reported at least one lifetime TBI. And they said that most of these traumatic events, most of these head injuries actually arose as they were engaged in sex work. And they, you know, in the sort of narrative form, talked about things like loss of consciousness, feeling dazed, having gaps in memory. So things that might just kind of fly under the radar if someone isn't kind of equipped to think about, well, what if this happened? And how do I then evaluate for some sort of physical trauma? Also financially vulnerable individuals. So impoverished, unhoused, unemployed people. And I also wanted to talk a little bit more. Dr. Zussman introduced us to strangulation. Victims that report non-fatal strangulation are significantly more likely to report having been sex trafficked on the street. They're 2 times more likely to report being threatened with a weapon, a gun or a knife by their trafficker, and 2 times more likely to report being brought across state lines for prostitution. So we're seeing that, you know, when people talk about strangulation events and have sort of those presenting symptoms, it's highly, highly likely that they've been involved in some way in exploitative behaviors. So I'm gonna turn it over, I think, to Dr. Monahan.
Thank you, Mandisa. Very, very interesting group of studies that you have there. So it highlights the range of the kinds of trafficking instances that occur. I want to thank First Lady Edwards and Dr. Hunter for inviting us here today. Dr. Hunter, was I supposed to wait for your introduction? You can see how eager I am.
I would love to introduce you, but if you're on a roll and you want to just keep going, by all means.
Well,
So
I also wanted to thank the esteemed First Ladies as well, and everyone that's on this webinar who serves a different role. It's just a very exciting event to be at, that all these people are moving and trying to get this to change.
Thank you, Dr. Monahan. I'll just take a minute to share with our audience your incredible experience, and we're so thankful to have you. Everyone, Dr. Monahan is an associate professor at the School of Social Welfare at Stony Brook University in New York. She's published widely and is also in private practice. Since her seminal article in 1999 entitled Head Injury and Battered Women, An Initial Inquiry, her research focus is on acquired brain injury as a result of IPV, or intimate partner violence. In January 2024, she received a $25,000 award from the Long Island Network for Clinical and Translational Science for her study on brain metabolism and cognitive impairment following traumatic brain injury of domestic violence shelter residents. So we're so thankful to have her. She has a wealth of knowledge and experience as well. So Dr. Monahan, we go ahead and continue. Thank
Thank
you.
you. I'm not sure if I'm forwarding the slide. Okay, thank you. So I want to start off because Mandisa and Dr. Sussman have wonderfully laid down the tracks of what we're looking at in terms of injury with a traumatic brain injury, a head injury, and what happens for the person, what mechanically happens for the person. But I also want to focus on the fact that brain injury resulting from human trafficking is a human rights violation. It impairs the person's ability with employment, with relationships, parenting, and it's not the ability to parent, it's the way that parents parent. Though it changes the parent's approach because of memory issues and just overall the ability to navigate through daily life. This is a human rights violation, and I also feel it's a social justice issue. So I also want to present the case of Tina. I think that presenting a case will help us vocalize what we're looking at and see the ramifications on a long-term, on an acute basis, but also a long-term basis for what happens for that person that's trafficked. And again, there's many different forms of trafficked. So I'm using a family member who has trafficked a child. Tina is the oldest, she's 14, of three sisters, Jane, age 12, and Debbie, age 10. Tina's father was physically abusive to all family members, and her mother divorced him when Tina was 5. 3 years later, Tina's mother married Sean. Almost immediately, Sean started to sexually abuse Tina, who was now 8 years old. When Tina was 9, Sean started to sell Tina to other men, as well as trading photographs of Tina during the sexual perpetration. During this time, Tina's mother was battling breast cancer and died when Tina was 12. Tina thought of running away quite often, but she was fearful of what would happen for her two younger sisters if she left them behind. Sean was also physically aggressive, hitting Tina on the head or the face, and often strangling her before raping her. She reports that she often had headaches and numerous times could not remember things. In particular, her grades in school were failing, and she was frequently the class target of laughter when called on by the teacher because she could not remember things, even if they were just discussed. Tina's abuse ended at the age of 14 when Sean raped and strangled her, and her sister Jane called 911. Police arrived to discover Tina unconscious. She was hospitalized, and Sean was arrested. So this case illustrates how a child can be trafficked even by their own family member. The other thing I wanted to mention was that Tina's images were posted on websites around the world, globally. And those images stay on the web in perpetuity. So she cannot get those images removed. She can sue for anyone who is downloading her images, but she cannot ever, it's impossible actually, to try to get those images removed. I want to talk about first responders who arrive at the scene. And as Dr. Sussman mentioned before, first responders, particularly police officers, have a really hard job when they arrive at a scene that might be volatile. It's probably the most dangerous kind of situation that there could be for a police officer. So first responders have a dangerous job as they are the first to arrive at a scene, and trafficking situations can be volatile. First responders secure the scene and then assess what has happened or is happening. In those moments, first responders may be assessing injuries. What we need to remember is that the brain injury may be invisible. And if we don't have a first responder who's been trained, then he or she may not be looking for that invisible brain injury. So for instance, as Dr. Sussman mentioned before, if a woman can't give you a timeline, if she can't tell you, well, first this happened, then that happened, and then that happened, automatically that should send up a red flag. Something is wrong. Something is missing. Doesn't remember what happened. I don't know. One minute I was here and the next minute I was at the bottom of the stairs. So that's memory loss. Also, if she's confused, if she's not making sense, if the story bounces around from this thing to that thing to this thing, and if her talking sounds slurred or sluggish. Very often, if a person has been strangled, their hyoid bone, the one bone in your body that controls your tongue, is damaged. And so that woman may be talking like that because her hyoid bone has been damaged. However, the first responder may believe that she has been drinking or drugging. If he or she doesn't know to ask, have you been strangled? Have you been choked? Because those terms get used intertwined, then he's not going to know the answer. He's going to assume a certain course of events. These are all indicators of brain injury, yet women have been called repeatedly for historians or they're making this up. Also, many of these women have experienced more than 2 adverse childhood experiences, and childhood abuse is dominant in this population, and brain injury may have been significant from childhood on. And that's another consideration that people don't think about. Other presenting symptoms include difficulty with balance, as Dr. Sussman mentioned, loss of time, difficulty with timeline or memory, difficult talking, swallowing, as I mentioned, headache, and light sensitivity. All of these things Dr. Sussman mentioned before. However, a lot of these things, particularly the loss of time, are translated to psychological symptomatology. If she has a loss of time, perhaps she's dissociating. That's what's going on. Working with forensic nursing to include brain injury as part of their assessment. That is increasing, thankfully, but we still need to make sure that people are doing that. Forensic nurses are doing that. In Arizona, there's a ride-along program that rides with first responders. They ride actually a little bit after the scene has been secured, and they have a specialized van where they will evaluate people. And they also have a conduit from their shelter in Phoenix, Arizona, right to the medical facility. Traffickers will typically hit their victims in the back of the head. Hair always hides bruising. A punch to the jaw, cheek, a broken tooth, black eye, or even shaking a person can cause a brain injury. So when you ask, were you hit in the head? Remember that even a slap can put the head in a coup de coup. We call it a coup de coup, back and forth, and the brain is going back and forth, back and forth. So even a hard slap on the face can cause an injury. So increase that question. Anecdotal information indicates that the trafficker will strangle the person while banging their head against an object. So again, this I think is increasing. I do consulting in the shelters, and I hear this more and more often. Whomever, trafficker, batterer, is got the woman by the neck, and while he is strangling her, he is banging her head against the wall. So it's a double whammy, so to speak, that she's getting it from loss of oxygen, oxygenated blood to the brain, and her head is being banged. There's a high correlation, once you've been strangled, there's a high correlation to femicide. Once you've heard that a person has lost consciousness or has been, the person has attempted to strangle them, your ears should go up that, this could be a situation leading to femicide. Every year, 3 to 4 million women in the US are abused. 15 to 1,600 are killed by their abusers. Now, that's just intimate partner violence. The trafficking situation is totally different. Adds to, but it's totally different. And again, the emergency department, acute assessment is increasing. I know when I meet with a woman, particularly in my study, people will ask about brain injury. We'll say, okay, if I'm working in the shelter with a woman and she says, well, I don't remember this, I don't remember that, I'm having trouble with this. We talk about brain injury. And the woman will say to me, so you think I might actually have a brain injury? And I'll say, I'm not an MD. That's beyond my scope. But you need to go for further evaluation. I think we both agree on that. She will agree. And then she'll look at me and she'll say, oh my God, thank God that you said that to me, because I just thought I was stupid. I've been told I was stupid. This is much like the case that Dr. Sussman said before. We hear this over and over and over again. I think it's a tragedy to hear that. But at least now they're on an avenue where recovery is possible. EDs provide the function of allowing the person to get further evaluation and also to get on a pathway for recovery with a concussion clinic or some sort of avenue where they can be evaluated. One thing I want to say about the emergency department that I think is really very important is if someone goes to the emergency department, if they're not going with an advocate or a representative, make sure if you're an emergency department person, make sure that you get that person alone when you're asking them, do you feel safe? Do you feel safe at home? Do you feel safe at work? Or do you feel safe going out? Because we know people have been kidnapped to be trafficked. You want to ask them that question when they're alone. Often I have seen women being brought to the emergency department by members of the family of the abuser. And he does that to make sure that she doesn't report. Same thing goes on with traffickers. This is a table that I put together that looks at the overlap between head injury symptomatology and PTSD symptoms. And to me, this is scary because they overlap. Yet, as a gender bias, if a woman is reporting these kinds of symptoms, she gets the diagnosis of PTSD. She doesn't get the brain injury diagnosis. And if I had another clone of myself, I would do a study where I sent 2 cohorts, male and female, with the same kinds of symptoms to an ED, and then see what kind of diagnosis we come up with for each group. And I would almost bet my house that the men would get the brain injury diagnosis and the women would get the PTSD. Okay. The justice system, more and more efforts are being made to inform lawyers, judges, and advocates regarding the ways to assess for brain injury and the acute and long-term difficulties for those trying to recover. The long-term difficulties, as Dr. Sussman said before, are scary. Those are the things that scare me because that's waiting down the road. Gaslighting, we know that happens all the time. And legal reform needs to occur, new legislation. As I heard before at the beginning, with introductions, legislation is happening. And the shelter system, we are now changing this shelter system. It's becoming more and more open to looking at different kinds of things that are going on. However, more and more of those shelter staff need to be educated. So when I go into the shelters, I hear all these different kinds of stories. Margaret had an eligibility appointment at DSS and she missed it. She then missed a pediatrician's appointment so that her child could be registered for school. The staff wondered if she was lazy or if she was using substances. Of course, my question is always, does she have a brain injury? Okay, people look at me and they want to run away. Here comes the brain lady. She's going to ask us if we did all this stuff, and we're going to have to tell her no. So, I'm going to keep saying, you need to do this. You need to do this. Darlene was reluctant to sit in the shelter kitchen, and when she had to, shielded her eyes because the lights hurt her. That's an indication. She also complained of headaches and slept through the time to get her children out to the bus. Pauline would lose concentration and just stare off. People assumed, again, going to a psychological diagnosis, that she was dissociating. Again, if we don't look at, even looking at the family, as our case with Tina, that something was going awry in that family system, then what are we going to do? If we don't start looking at those things, what will happen? Again, this is my saying to my supervisees, did you look at a brain injury? The shelters on Long Island are starting, they now know in their intake process to ask about a brain injury. The question becomes, how do we help women who recover? So as Dr. Sussman had, SCADs are really good suggestions before. So keeping a calendar on the refrigerator, setting your phone alarm. So if you need to be reminded about an appointment, lowering sounds, making sure the lighting is adjusted, making sure that she's getting an accurate evaluation, and then is in contact with a concussion clinic or a neurologist that can help her, someone that can guide this person in the recovery process. A danger assessment, I always have people in the shelter conduct danger assessments to know how lethal that person is. But in terms of brain injury, if you've received a brain injury from anyone, you need to stay away from them. That's my advice, even though the danger assessment looks at guns, previous criminality, arrest records, etc. We need to advocate for these people. And I think the overarching theme is that we need to have more trauma responsive care. So we know trauma informed, everybody's trauma informed. Everybody in the country knows what trauma is. So everybody's trauma informed. We need to be trauma responsive. Trauma responsive means you're being trained to know what to do when you see brain injury and trauma. So a trauma responsive brain injury aspect. And I'm going to hand it back over to Dr. Sussman.
And going back to our methodology of public health and social services, starting point, and each of us are somewhere on this timeline. And I hope that the takeaways from this conversation, as we're putting all the pieces together, the information about what is a brain injury, the information about does brain injury occur in trafficking, and Dr. Monahan's lovely presentation about what do we do now? How do we handle someone with a brain injury who comes in for services? So the first thing is, I think we want to take away that brain injury is absolutely occurring. It's occurring at a higher rate and level than in other types of abuse. It's also including strangulation. So we're getting the primary brain injury, we're getting the cumulative effect without a recovery period, we're getting more lifetime brain injuries than any other risk group, and we've got that oxygen piece. The next one is everyone who is currently being trafficked or is a survivor, we need to be thinking based on Mandisa's numbers, somewhere between 70 and 90%. We need to be asking those questions, and we need to be thinking about when somebody comes in with that experience and they share that with us, do they need a paper and pencil to write down what our recommendations are? Do we need to pause and maybe take one issue at a time rather than overwhelming with too many things? And then this idea that this brain injury was invisible. I would love to ask in the chat if there are individuals here on the call today who feel like maybe now that they've learned more about brain injury, do you feel like maybe there might be some clients that you're working with, or patients that you're working with, or victims that you're advocating for, and survivors that you're fighting for, who maybe have some signs and symptoms of brain injury? And when we talk about brain injury responsive care, looking at these numbers in the trafficking world, should it be brain trauma and brain injury responsive care rather than trauma responsive care? Do we actually need to add that brain injury to give voice to what Dr. Monahan shared with us, that right now we're dealing with the bias where the men get the brain injury diagnosis and the women are told it's trauma and it's emotional? And do we have to actually call that out? So we all know, almost everybody on here, I'd say either played sports or has a kid who played sports or a grandchild who played sports. We know about concussions. We don't need to do that training. What we need to do is we need to take what first responders and everyone else are currently doing related to sports, and we need to just open it up and apply it to children who are in the foster system. We need to apply it to survivors of domestic and intimate partner violence. And I think we have a mandate to include brain injury assessment for 100% of people who have been identified as having experienced trafficking. And I want to conclude with a quote, and I get a little chill when I think about it. I met First Lady Donna Edwards about 8 months ago, and in about 2 minutes, she got me connected with trafficking. And one of the things she said, in addition to asking me, what is the average age of someone who's trafficked in the state of Louisiana and around the country? The answer was 14. When you amalgamate the child and the adult ages that Mandisa showed us, 14. And so I want to add to line 1, it's not just the prevalence. It's not just that it's double with the repeated events. It's not just that you add strangulation. But this is all happening to a developing brain, to someone who's trying to learn in high school or middle school, and who then has to go figure out how to make good decisions in their life and get a job. So I feel like the group here today has identified something that's upstream, that's a causative factor of so many of the downstream harms. And I have to say, Mrs. Edwards, now that I've seen it, I can't unsee it.
Thank you so much, Dr. Zussman. I appreciate your comments. Dana?
Wow, this is so powerful. And I know that our audience, I see some of the comments in the chat that, now that they've learned more about traumatic brain injury and what the symptoms of brain injury, that perhaps they have missed it in some of their clients or patients that they serve, or perhaps they've seen symptoms and now they know what could be happening, and it could be traumatic brain injury. So thank you so very much, Dr. Zussman, and future Dr. Mandisa Kezwa, who had to hop off, but we're so thankful. And Dr. Monahan, thank you so very much. And so at this time, we would like to just have some conversation. First Lady, former First Lady Edwards or First Lady Hutchinson, did you all have any comments first? And then as people put their questions in the chat, we'll start opening it up for questions. And I'll direct the questions to our presenters.
Okay, well, thank you, everyone. I'll finish up at the end. So I'll go ahead and ask Susan Hutchison, do you have anything, Susan, you'd like to add?
Well, this explains a lot because I also get around folks with domestic violence, and it's really an eye-opener as to the decision-making that we see so many times in domestic violence, women particularly. They're not being reasonable. They're not being logical. They're not being rational. They keep going back. They keep going back. And this kind of is an eye-opener to me that maybe this is a huge part of it. It's not just how they feel about the situation, but things are just not clicking for the brain. And I'm anxious to make sure that our domestic violence folks know about this, and we We have a great one, Women and Children First, and they're working very hard to create what they call a peace center. This is something of a movement that's elsewhere in the country, and trying to have all the services right there so they don't have to be taken to this appointment and that appointment for restraining orders and so forth and so on. And meetings that we can bring it all there, and children's advocacy centers. One in particular is working with them to have availability of our counselors for trauma-focused cognitive behavioral therapy, which is directed to mental health, but sometimes the children are involved in physical violence as well, not just sexual, or not just witnessing their loved ones being battered. So this is all encompassing, and a component I'll be sure to pass along and all throughout. And I'm sure we have people looking from the children's advocacy centers, or who will see this recording and implement that and find a way to invoke it in. I'm sure the Attorney General's office will put it out there, and it's something to share with our law enforcement. We just don't think about these things. The state of mind might be something of a permanent injury that needs to be addressed. So thank you, thank you, thank you. I just admire you more and more, Donna,
May
for bringing
I
these things
respond,
together.
First Lady Hutchinson? May I respond to that?
Yes.
First, I want to thank you for pointing that out. And for decades, I have thought, you know, yes, women go back. They go back for a variety of reasons, economic. They want their children to know their father. They still love the guy. They go back for a variety of reasons. But I have been convinced for the past 20 years, since my first study, that they go back because their judgment is off kilter.
Yeah.
Because anyone seeing this kind of danger would know that the danger is going to occur again.
Right.
They would know it. Anybody
Right.
around them is telling them, you can't go
Yeah.
back. He's going to hurt you. So something is off kilter. And I think it's that brain injury that impedes that thinking about what
Yeah.
are the consequences? What's the abstract reasoning? What's the long term? Can I focus my thinking, my concentration, and what's going to be the outcome? So thank you for picking up on that, and thinking about getting out there and telling people, because that's how
Well,
it's end.
knowledge is power. Another issue that y'all may have addressed in one of the other summits too, we don't think about it, is the emergency room. The emergency room personnel, doctors, nurses will readily tell you, as they have told me, they don't know. They don't know the red flags. But if there's one thing a sex trafficker does besides abusing and hurting and all that, they want to keep them alive. So if there's some sort of health issue, they'll bring them in to the emergency room because it's easier to keep them alive than to recruit somebody else. This is what I've been told by the specialist here. And we don't recognize them. And we don't, and I've told the top brass at the hospital, and that's another area of movement that we need to make. Thank you so much.
Thank you all. We have a question in the chat that I'd like to pose to the presenters. It says, I'm a therapist and had a juvenile male client with a history of head injury, multiple fist fights, who was experiencing memory loss, severe dizziness upon standing, vision changes, hallucinations, and emotional dysregulation. I recommended an evaluation by a neurologist who said, without imaging, everything was psychological and referred back to me for therapy. Says, note, the child has Medicaid insurance. What does evaluation for TBI typically entail, and should I refer for a second opinion?
So I would like to take that question. I want to say that you are one of the rare mental health providers who actually take a great medical history. I can make the diagnosis of traumatic brain injury with subsequent sequelae just from your little message in the chat. So we've got gaps. Former First Lady Hutchinson called out gaps in our first responders, in our emergency department, even in the concussion clinics. We've got folks who are used to seeing athletes. They're used to seeing 6-foot tall men with a single injury. And we are going to have to think about how do we expand an understanding of what brain injuries look like, what chronic brain injuries look like, what someone, like in this case, who had multiple childhood injuries, looks like as an adult. And I just want to say, yes, please get a second opinion. And if you'd like to communicate with me afterwards, we can look at some of the resources that may be available in your community.
Thank you, Dr. Zussman. Another question, could brain injury occur as a result from emotional abuse tactics such as gaslighting?
So we've got data on this. We do know that, people who haven't been in an emotionally rich environment make fewer connections within their individual brain neurons. And so there is a precedent and there is data that emotional abuse alone, and particularly neglect, can lead to changes in the brain. But I would ask the deeper questions. I am like Dr. Monahan, enough gray hair here to say that there's something behind that. And my young people, what they'll say when I'll say, well, tell me about your childhood, they'll just say, I don't remember much about my childhood. It's like those are the buzzwords, those are the code words. You guys probably know that 50% of the women who joined the military, the service today, are the incredibly resilient survivors of abuse in their homes or abuse in their communities. 25% of men. So the individuals, the face of domestic violence and trafficking sometimes is a beautiful woman putting on their lipstick.
Thank you. Another question. I was strangled as a teenager. I had a situation a year ago where I almost completely lost vision in my right eye. Could this be a delayed symptom of being strangled, choked as a 15-year-old?
Dr. Monahan, do you want to take this and I'll comment after?
I don't know. Honestly, I don't know, but I would get that evaluated.
And I'm in agreement. So the first is I would take it as a new symptom. The transient loss of vision needs to be evaluated urgently because it can be in a stroke family and it can be in an eye related to the ophthalmologic issues. But we do know that 1% of people who've had strangulation have a lifetime history of delayed stroke. So we just wrote a brief for the United States Supreme Court that talks about the fact that anybody within the first 24 hours of a strangulation event, particularly if it's associated with traumatic brain injury as well and/or loss of consciousness, that 24-hour window, that needs to be emergency level care where there is imaging of the blood vessels due to the increased risk of stroke. That's an excellent question and an important one.
Thank you. And last question. Are there any assessment resources for TBI that are kid-friendly or can be used with kids?
I don't know of any particularly for children.
So there are guidelines for concussion screening that, again, remember, we've got data from sports. So out of Emory, Dr. Andrew Reisner headed a national and international team. I actually spoke on a panel with him at the World Health Organization in Cape Town, South Africa. So if you Google concussion guidelines or concussion evaluation for kids, and there's a separate place on the Emory website, but you can use all the sports concussion guidelines to think about children and adults.
Thank you. And at this time, I want to thank everyone. I know we have more questions in the chat. We will take your questions and share them with the presenters after this. And within a few days or give us a week, we will make sure we respond to each question. So thank you all for putting your questions in the chat box. And so at this time, I'll turn it back over to Mrs. Edwards.
Thank you, Dana. Well, I am sure, like myself, you all have learned a lot of great and good information today. That's the purpose of these summits, to convene leaders in the field to share knowledge that will help providers and professionals in their day-to-day work with victims and survivors. And I want to express my gratitude to each of the first spouses that joined us, as well as the presenters for your commitment to addressing human trafficking. This is so huge, and the more we bring awareness to it, the more prevention comes through. We have learned today information that will help us to identify if a victim may have more complex needs due to traumatic brain injury and what that looks like. So if you have questions or for any of the presenters, or if Dr. Hunter, please do not hesitate to drop us a question in the chat box like you did earlier. We're going to copy those and, like Dana said, and send them over. Or you can send us an email at louisianafirstfoundation@gmail.com. That's louisianafirstfoundation@gmail.com. We're also pleased to be able to offer approved continuing education credits for social workers and counselors today. So if you would like a certificate to verify your participation and for your CEUs, please email us your first and last name to louisianafirstfoundation@gmail.com and put CEUs in the subject line. We would also ask that you complete our brief survey and give us some feedback on the summit. You can also share with us topics that you may want to see in future summits. You know, and I think we're going to do one more before the end of the year. So as we think about some of our most vulnerable citizens, our brothers and our sisters, let us remember to show them love and kindness and compassion. And I want to thank you all again, and please be on the lookout for our upcoming newsletter and dates for future summits. And I look forward to our continued collaboration in this important effort. So God bless each of you. Thank you so much.
Thank you.
Thank you. Amazing work, ladies. Thank you so much.
Thank you. Bye-bye.
Bye-bye. Thank y'all.
Thanks so much, Donna. Bye-bye.
Thank you.